Start. Good evening, everyone, and thank you for joining us tonight for this really important webinar on stroke management in general practice, specifically in the ACT. We have some fantastic speakers for you today, so I have no doubt you'll find this session extremely engaging and informative. My name is Kayla Viney, and I'm the Stroke Prevention Manager at Stroke Foundation, and I have a Master's in Public Health. More than 80% of strokes can be prevented. So general practitioners like yourselves are ideally placed to help prevent strokes by identifying high-risk patients, educating them to recognise the signs and manage their risk, as well as providing early interventions and referrals to other specialists and services, and implementing rapid action plans in the event of stroke. This event is brought to you today by Stroke Foundation in partnership with Capital Health Network and supported by the ACT Health Directorate. We hope this webinar supports you and your practice staff to save lives and improve long-term recovery from stroke. Before we begin, Stroke Foundation respectfully acknowledges the traditional owners and custodians of country throughout Australia and acknowledges their continuing connection to land, water, sky, and community. We pay our respects to peoples, cultures, and elders, past and present, for they hold memories, culture, and hope of their peoples. I would like to acknowledge that I am joining you today from the lands of the Southeastern Kulin Nation and the Bunurong people. Now, before I introduce you to our wonderful presenters tonight, I want to do a quick poll and run you through some housekeeping. So first, some housekeeping. An interactive webinar is a good webinar. We really encourage you to use the Q&A function at the bottom of your screen to submit your questions as you think of them. Use the Q&A function rather than the chat. We will answer these questions in the second half of our session tonight. If you see a question that someone else has asked and you want it answered, please give it a thumbs up and vote or upvote that question. Now we'll quickly run a poll on stroke tonight so we can gauge the room. So I'll give you a few moments to complete these questions before I begin introducing our speakers. So if you can see those poll questions coming up on your screen, you can start to answer those now. I can see some answers coming in, so I'll just give you a few more moments. Now, while you're finishing that poll, I would like to welcome our wonderful speakers, Dr. Afshin, Sharla, and Lillian. Dr. Afshin is a neurologist with nearly 20 years experience in diagnosis and treatment of stroke patients and general neurological disorders. He received his specialty board certificate in neurology in Iran in 2002 and did his research fellowship in vascular and interventional neurology in the USA in 2010. Dr. Afshan now works in as a clinical neurology fellow in Canberra Hospital. Charlotte Cohens is a UK qualified registered nurse with over 12 years experience in nursing and has worked in stroke units in Australia for 10 years. She has a postgraduate qualification in stroke management and is currently employed as a stroke nurse navigator at Canberra Hospital. Lillian Chen is a stroke safe speaker from Stroke Foundation. She's a stroke survivor and a retired pharmacist. Lillian will share her story of lived experience with you tonight. On behalf of Stroke Foundation and Capital Health Network, I'd like to thank Afshan, Sharla and Lillian for their willingness to share their knowledge and expertise with us tonight. We really look forward to learning from you. I now hand it over to Lillian.
Good evening, everyone, and thank you for this opportunity to speak to you tonight. Yes, I am a stroke survivor. I had my stroke about 4.5 years ago when I was 49. In my role as a volunteer stroke safe speaker for the Stroke Foundation, I enjoy speaking to mainly community groups about what is a stroke, how to recognise the signs of stroke, and how to prevent stroke. In my talks, I tell everyone to think fast. F for face, A for arms, S for speech, and T for time. As I tell you my story, I will show you how knowing the fast signs of stroke saved my life. I also want to share some misconceptions that the public have about stroke. This is my stroke story. It was an ordinary day. My husband and I had just come home from a busy and stressful day at work, and so we decided to relax in the spa pool after dinner. After the spa, I decided to have my shower first while my husband stayed downstairs to watch television. I managed to have my shower, and then I made my way downstairs to get a drink of water. Now, my husband remembers seeing me walking towards him and thinking, and he thought that I looked angry to him. Perhaps because he was still sitting on the sofa in his wet swimmers. But anyway, I wasn't angry with him at all in this instance. I had just suffered a right brain ischemic stroke, and so the left side of my face was drooping, and that's why he thought I looked a bit strange. I went to sit down next to him, but instead I slumped onto him. Surprised, he asked me if I was okay, and I said that I was fine and that I was just tired. So he said, well, let's just go straight to sleep. I tried to stand up, but instead I went straight down onto the ground, onto all fours, and I couldn't get up. That was when the alarm bells started ringing for him. He shouted up to my sons who were upstairs to come down and help. My youngest son only had to take one look at me to know that something was very wrong, and he rang 000 immediately. My husband spoke with the 000 operator to let them know that he suspected that I had had a stroke. They also asked him to check to see if I could raise both arms. Now, the funny thing is I actually thought I was raising both arms, but to everyone in my family, they could see that I was only raising my right arm. It's important to note here that the inability to raise both arms is the sign least known by most Australians. My husband also noticed that my speech was slow and slurred and that I was dribbling. 2 ambulances arrived pretty quickly, and I was taken to my local hospital. I was checked in emergency, and I also received a CT scan, which confirmed that I had experienced a major stroke. I was given a thrombolytic, and a transfer to Royal Prince Alfred Hospital was arranged for me to have clot retrieval surgery. My husband remembers riding shotgun in the ambulance and guiltily enjoying the fast ride to RPA in the middle of the night. What I remember is finally waking up in ICU after the operation, pretty happy and relieved to know that I had survived. Now, I just want to talk briefly about T for time, as timing is critical for stroke treatment. In our talks, we urge people to ring 000 immediately if they suspect a stroke. So why is it important why others know the signs of stroke? Well, the person having a stroke may not know they're having a stroke, or they may even deny it. Remember with my story, I said that I was fine and that I was just tired. Luckily, my family ignored me this time and called 000. I do sometimes think about the outcome if they hadn't been around or if they hadn't rung 000. So these are the fast signs as they relate to me. I also experience balance and eyesight issues as well. All strokes are different, but all strokes are life-changing. After my stroke, I felt really tired for months. So tired, I couldn't move. I couldn't even get off the sofa. I also had a frozen left shoulder for about 9 months. And for a very long time, I was amazed every morning knowing that I survived another night, scared that I would have another stroke. In our Stroke Safe talks, we emphasise the importance of having regular health checks with their doctor, particularly if they're over 45. We give out this handout, I hope you can see it, called a stroke risk factor tick test, which has questions about their lifestyle and medical risks so that they complete it later after the talk and suggest that it's a great way to start a conversation with their doctor. We also provide them with other handouts as well. I also wanted to make a quick mention that most people that have attended my talks were surprised to hear that strokes can happen to anyone, anytime, and any age, thinking that it only happens to older people, when in fact 25% of strokes happen to those of working age. Many also did not know that strokes occur in the brain. So these are some reasons why the Stroke Safe talks and your help in stroke prevention and recovery are so important. My stroke came from out of the blue, and to this day, I still do not know the reason for my stroke. But what I do know is that my family's fast thinking and knowing the signs of stroke, they saved my life. I've received treatment quickly and I made a pretty good recovery. Thank you for listening to my story, and thank you for increasing stroke awareness in the ACT. Please speak with your family, friends, colleagues, and patients about FAST. Thank you.
Thank you so much, Lillian. You're truly inspiring. It's so important to listen and learn from people like yourself with lived experience. So thank you so much for being willing to share your story tonight. I know everyone will have really appreciated it and learned a lot from you.
My pleasure.
Everyone, please remember to pop any questions you have for Lillian in the Q&A, and we will come back to them at the end of the session. I'd now like to hand you over to Afshin.
Kyla, can you see my screen?
We can
My
see.
slides?
Thank
We
you.
can see. Okay, good evening, everyone. And first of all, I want to thank Kyla, Amanda, Lillian, Kunal, and Shala for helping me to having this webinar about stroke management in general practice. Actually, learning outcomes are mentioned here. I skip up. My agenda is mostly about stroke burden in Australia, risk factors for stroke outcomes, providing a case study to know how to manage the risk factors and how to prevent stroke, and if stroke happens as a GP, how can we manage stroke? Okay, about the stroke in Australia. For a 45-year-old man, Australian man, the risk of having a stroke by age of 85 is 1 in 4, about 20%. For women, it's about 20%. And the most important thing, regional Australians are 17% more likely to suffer a stroke than those in metropolitan areas. So the burden of a stroke is larger for Australian people who live in rural and regional areas. And some stroke facts and figures. A stroke is the third leading cause of death for Australian people. The first one is ischemic heart disease. Second is dementia, including Alzheimer's disease. And the third one is cerebrovascular disease. More or less about 450,000 Australians living with stroke. They are victims of stroke. And unfortunately, two-thirds of these stroke victims are dependent to other people for daily activities. The financial burden of a stroke is about $6 billion each year for Australian government. So stroke has a huge burden in terms of persons, families, and society. What's the stroke risk factors? I think as a knowledgeable GPs, you know that we have two types of stroke, ischemic stroke and hemorrhagic stroke. Ischemic stroke includes both thrombotic stroke and cardioembolic strokes, and hemorrhagic stroke includes both intraparenchymal hemorrhage and subarachnoid hemorrhage. In all populations, ischemic strokes are more common in terms of about 4 to 1. I mean, 80% of all strokes are ischemic, and about 20% of all strokes are hemorrhagic. Practically, risk factors are ischemic and hemorrhagic are the same. Hypertension is the most important modifiable risk factor for both ischemic and hemorrhagic. Smoking is also is an underlying risk factor for both of them. Diabetes mellitus and cardiac causes, particularly atrial fibrillation, AFib, are predisposing factors for ischemic strokes, and also obesity and particular apolipoprotein genetic factors are working for ischemic strokes. But about non-modifiable risk factors for stroke, the most important thing that actually Lillian mentioned is although a stroke happens mostly in senior citizens, a stroke can happen for any age, any age. I always say even fetuses can have a stroke. Neonates can have a stroke, children can have a stroke, and most importantly, we define young adult stroke in some literature less than 55, in some literature less than 45. If you consider less than 55, about 13% in 1993 and 19% of strokes in 2005 was less than 55. It's huge. It means that about 1/10 of stroke patients are in working age. In terms of gender, because in all populations, women have longer lifespan, all in all, actually the prevalence of strokes are more in women. About ethnicity, in different population, different ethnicities have different predilections. For example, in the United States, African Americans have more intraparenchymal hemorrhage. Regarding Australian population, it's very important that Aboriginal and Torres Strait Islander people, hospitalization for stroke is twice as high as other Australians, and mortality is 1.6 times higher in non-Aboriginal population. So we can actually understand that stroke is more common in Aboriginal and Torres Strait Islander people, and also unfortunately mortalities are more in Aboriginal people. About stroke outcomes, unfortunately, even in 2023, stroke outcome is dismal. About 30% of stroke victims die within 1 month, 1 year. 35% will be permanently disabled. 25% are independent but cannot return to their baselines and not able to do everything. Only 10% of stroke victims are fully recovered. And not only mortality and motor dependence is important, other long-term complication of stroke is important. For example, depression, post-stroke depression are mostly overlooked. And it's important that post-stroke depression is not only a reaction to a disabling disease, but also sometimes is an inherent consequence of stroke. Also pain. Lillian mentioned that she had frozen shoulder syndrome. If we don't have a good rehabilitation, actually after stroke, many pain syndromes can evolve. So we should consider these long-term complications as well. And the most important thing, stroke is a time-dependent medical emergency. For each minute without an efficient treatment, patients lose about 2 million neurons, 14 billion synapses, and 12K myelinated fibers. These stats are huge, 2 million neurons per minute. So a stroke is a medical emergency. TI is a medical emergency. And reperfusion strategies should be done as soon as possible. Although we consider 4.5 hours window for thrombolysis or 24 hours window for endovascular clot retrieval. But the sooner is the better. The sooner thrombolysis and reperfusion strategies done, the outcome will be much better. So reperfusion strategies include both thrombolysis and endovascular clot retrieval or mechanical thrombectomy. About 35% of acute ischemic stroke patients are eligible for thrombolysis, I mean TPA infusion, alteplase infusion, and about 30% of acute ischemic stroke victims are eligible for endovascular clot retrieval. Thrombolysis can be done in any primary stroke center, but endovascular thrombectomy is done in comprehensive stroke centers. In Australia, we have about 9 to 10 comprehensive stroke center can do endovascular thrombectomy. So let's have a case study. I always think that medical knowledge is best understood with case studies. Consider David. David is a 62-year-old gentleman, recently moved to catchment area of your surgery. He has been to one of the Stroke Foundation's community stroke safe talks, and so requests a heart health check with you. Actually, you have a code MBS 6099, and you can consider risk factors, both for acute myocardial infarction and stroke. For David is 62. Unfortunately, David's father had a stroke at the age of 60 and became partially disabled, and unfortunately died at the age of 62 following the second stroke. David himself has history of tobacco use. He's an ex-smoker. He quit 20 years ago. And David consumes alcohol a little bit liberally, and unfortunately David has sedentary life, but David has no medical history of other diseases. In your examination, you notice that blood pressure of David is high. It's about 160 on 100. Pulse is normal, BMI 29 kg per square meter. Waist to hip ratio is of 0.95, but in pathology and in bloods, David has total cholesterol 6.6, LDL 4.2, HDL 1.1, TG 2.8. Blood glucose is 6.3, which is defined as pre-diabetic. Fortunately, David has no proteinuria, and liver function and other kidney functions are normal. So let's consider David's risk factor. For modifiable risk factors, David has hypertension, obesity, sedentary life, and age is, in twilight zone for developing a stroke. What about assessing absolute cardiovascular risk? It's very important that 64% of adult population in Australia have 3 or more modifiable risk factors for cardiovascular diseases. I mean, MI, stroke, and peripheral vascular diseases. All of you are familiar with CVD check. CVD check, it's actually a website, can calculate absolute cardiovascular disease risk calculator for your patients. It's very home user-friendly, and you can easily calculate risk factors for your patients. But the most important thing, for some groups, actually they are considered high-risk group regardless of CVD check scores. What's these groups? Diabetic patients more than 60, diabetic patients with macroalbuminuria, patients with moderate to severe CKD, chronic kidney disease, I mean persistent proteinuria or EGFR less than 45, patients with familial history with familial hypercholesteremia, patients with very high systolic or diastolic blood pressure. I mean systolic more than 180 and diastolic more than 110. Patients with serum total cholesterol more than 7.5 and Aboriginal and Torres Strait Islander more than 74. So these groups are considered high-risk group regardless of the scores in CVD. Again, diabetes patients more than 60, diabetes plus macroalbuminuria, moderate to severe CKD, familial hypercholesteremia, very high blood pressure, very high total cholesterol, but most importantly, Aboriginal people more than 74. So for David, risk, actually absolute cardiovascular risk factor for having a cardiovascular disease in next 5 years is 17%, and it's huge. But friends, just with starting antihypertensive drugs and statins, you can change 17 to 9. You can decrease cardiovascular risk factors by a half. So just with starting an antihypertensive drug and total cholesterol. So you, my respected GP friends, can be the first line of fighting with stroke and MI. About managing risk factors, this slide a little bit complex, but I just want to say that With high-risk patients, both lifestyle and pharmacotherapy. But for moderate risk factors, risk strata and low-risk strata, just with lifestyle management and only pharmacotherapy for particular groups, you can proceed to risk factor modifications. About lifestyle, physical activity is very important. Actually, we have moderate physical activity, we have strenuous physical activity, we have aerobic, we have resistance. I don't want to stress on numbers. You should provide information for your patients that physical activity is very important. How about moderate physical activity? Just walking very briskly, mowing lawns, bicycling with light efforts. But vigorous physical activity includes hiking, jogging at 6 miles per hour, shoveling, bicycling fast, basketball, soccer, or tennis single. Lifestyle diet, I know that you are very knowledgeable about healthy diet. Healthy diet should include as less as possible saturated fatty acid, trans unsaturated fatty acids, as zero, full of fiber, full of fruit and vegetables, fish, nuts, and as less alcohol as possible. Smoking should be cessated. And about hypertension, most of my GP friends ask which antihypertensive drug is appropriate for a stroke. Actually, the answer is the antihypertensive drugs, which is appropriate for general populations. And ACE inhibitors, ARBs, CCBs, calcium channel blockers, and thiazide-like diuretics. All they work for prevention of stroke. But the most important thing that is proven by many studies that an amalgam and a mixture of low dose antihypertensive drugs from different groups is much better than a high dose single antihypertensive drugs. So polytherapy with 2 or sometimes 3 antihypertensive groups with lower dose is better than monotherapy with higher dose. So another important risk factor is AF, atrial fibrillation. And with graying population, with aging of population, the risk and the prevalence of AF is increased. For AF, you are familiar with CHA2DS2 too. Actually, CHA2DS2 in CHA2DS2, C stands for congestive heart failure, 1 point. H stands for hypertension, 1 point. H, more than 75, 2 point. More than 65, 1 point. D is for diabetes, and S, 2 points for stroke or TI. If a patient has CHA2DS2 0, no antiplatelet, no anticoagulation. CHA2DS2 1, you can proceed to anticoagulation, but for CHA2DS2 more than 2, equal or more than 2, anticoagulation is indicated. The change that evolved during recent years that drugs showed their efficacy and safety. Nowadays, for non-valvular AF, we proceed to drugs like rivaroxaban, apixaban, dabigatran. Just for valvular AF, I mean AF plus mitral stenosis, AF plus prosthetic valve, we should proceed to warfarin. Okay, about diabetes and hypertension and hypercholesterol, I'm 100% sure you are much more knowledgeable than me. Coming back to David. David has high blood pressure and high cholesterol. So you can proceed to an antihypertensive drug, ARB or ACE inhibitor. If it fails to reach the target of 130 to 140, you can proceed to low dose of 2 groups. For example, low dose ACE inhibitors plus low dose calcium channel blockers, such as amlodipine. For lipids, you can proceed to any statin, atorvastatin, rosuvastatin, and also lifestyle management. But what if David had atrial fibrillation? If David has atrial fibrillation with age 62 and just blood pressure, CHA2DS2-VASc is 1. With CHA2DS2-VASc 1, you should negotiate with the patient. If patient is happy with anticoagulation, actually you can proceed to drugs. For David, because of the history of stroke in his father, he was happy to start dabigatran and non-vitamin K oral anticoagulant with dose of 150 mg. Okay. Another hypothetical conditions, if David have sleep apnea, type 2 diabetes, or chronic kidney disease. All of these 3 factors are risk factors for both MI and stroke. Or age. If David is 80, if David was 82 plus atrial fibrillation, age of 82, CHA2DS2-VASc 2, and also hypertension. So CHA2DS2-VASc makes 3, and anticoagulation is absolutely indicated for David. Okay, but what's missing from David's management? What do you think that? The most important thing is adherence. Just starting antihypertensive drug is not important. Just talking about lifestyle management is not important. We should monitor adherence of the patient. You know, as I immigrated to Australia, I noticed that Australian health system is one of the best health system all over the world. Why? Because GPs are the pillars of Australian health system, and patients GPs interactions are very good. So dear my friends, please monitor adherence of the drugs. So till now we talk about prevention of a stroke, but all and all the stroke happens. The stroke happens sometimes despite all our endeavors and efforts for fighting a stroke. But the most important stats for stroke is only 36% of Australians with stroke reached hospital within a critical 4.5-hour window for thrombolysis. We mean that only 1/3 of stroke victims in Australia reach to primary or comprehensive stroke units in therapeutic window. Actually, we lost about 2/3 of its stroke victims. And actually, Lillian talked about the factors: negligence of patients, negligence of families, and the most important thing, lack of awareness. And mode of transport. It's very important that patients with a stroke call 000 rather than driving themselves to the hospital. Actually, ambulances is the best way of transport. And you know, most of people are aware of heart attack manifestation, but unfortunately for a stroke, medical literacy is a little bit lower than literacy about heart attack. So we all increase public awareness with acronym of FAST. FAST means face droop, arms weakness, slurred speech. If this manifestation happen, time is important, call 000. Okay.
Stroke can happen to anybody at any age. The best way to help someone is to learn the signs of stroke and know how to act fast. F is for face. Has their face drooped? A is for arms. Can they lift both arms? S is for speech. Is their speech slurred? Do they understand you? T is for time. Call 000. Time is critical. If you see any of these symptoms, act fast. Learn the signs of stroke and you could save a life.
But FAST covers about 80% of strokes. But we have other manifestations of stroke as well. Actually, a new acronym can be BFAST. B as for balance and E for eye problems. Eye problems, not only visual field defects, but also double vision. So BFAST is another acronym, but FAST is very popular all over the world. Also, sensory manifestation of strokes, pins and needles, numbness, tingling, swallowing problems, changing voice, and most importantly, acute headaches. Headache is very common, but acute, sudden, explosive headaches should be considered as a manifestation of subarachnoid hemorrhage, intraparenchymal hemorrhage, and sometimes even ischemic strokes. So please be knowledgeable, not only yourself, but also your staff, your nurses, even your receptionist should be knowledgeable about FAST and clinical manifestation for a stroke. I eagerly recommend that you talk with Stroke Foundation and prepare these catalogs, brochures, and posters. It would be nice that one of the FAST posters is in your surgery, will be hanged in your surgery. Okay, coming back to David. We did our best to prevent stroke for David. David was 63, with atrial fibrillation, hypertension, and smoking. The other day, David calls your practice receptionist at 10 a.m. to report a funny turn. On questioning, he says he experienced temporary slur of the speech and left side weakness that lasted about 10 minutes. He says he feels better now, so he's no longer slurring his speech, but he still feels a bit shaky and wonders whether he should make an appointment to see the doctor. What's your response? What the receptionist should answer? What you will answer? The most important thing, don't come to our surgery, call 000. It's very important that this is a TIA. This is a typical presentation of TIA. And for TIA, please answer, don't come to our surgery. Actually, you should call 000 and you should be transferred to a hospital with abilities to care patients with TIA and stroke. TIA is a medical emergency, and the most important fact for TIA is the highest risk of stroke occurring following TIA is within the first 2 days. So TIA is a medical emergency. We have a high risk of evolution of TIA to well-established stroke in the first days. So TIA should be transferred to a hospital. About management of TIA and the stroke, here at Canberra Hospital, we follow the most recent and newest guidelines. We reperfuse with thrombolysis within 9 years, and we do endovascular thrombectomy within 24 hours. And we have stroke response services. What are stroke response services? Actually, stroke response services is very important that all Australians, not only metropolitan Australians, but also Australians who live in rural and regional areas, have enough access and equal access to quality of care of stroke. So ambulance, actually lots of programs and webinars and educational modules have been done for paramedics, and nowadays I think that Australian paramedics are very knowledgeable about the manifestation of a stroke and early management of strokes. And also many hospitals have screening imaging. In Australia, screening imaging is mostly by CT. It's 24/7. It's safe, it's cheap and non-expensive, and the most important thing, it doesn't need that the patient would be still. And we have all over the world, including Australia, we have different policies. One of these policies is this: drip and chip. the patient comes to a referral hospital with primary stroke care. CT scintigraphy is done. If eligible, if the patient is eligible for thrombolysis, thrombolysis is done here. If the patient has large vessel occlusion, transferred to a hospital with endovascular clot retrieval access. Another policy is mothership policy. With mothership policy, the patients actually bypass the hospital with lysis and directly transfer to a large hospital with both access to lysis and clot retrieval. There are cons and pros for these two policies. In Australia, particularly in New South Wales, we have a telehealth policy, which is very helpful. Actually, the patients are transferred to a referral hospital, district hospital, and there are some telehealth stroke communities which cover these patients. Sometimes examine the patient, most of the time review the CT angiography of the patient, and actually it's a specialist rendezvous. And if the patient needs to be transferred to Sydney hospitals or Canberra hospitals, these patients are transferred to hospitals with endovascular clot retrieval. Mobile stroke unit, it's just available. We have two mobile stroke units in Melbourne and one in Sydney. It's not available in ACT. And how about our stroke response services? Our stroke response services in ACT have some special characteristics. Actually, our paramedics in ACTAS, ACT ambulance services, are familiar with CREST. CREST is a pre-hospital scoring system that can provide a good actually evaluation and assessment for stroke risk for our ACTAS paramedics. Another thing is pre-notifications system. Actually, me as a stroke fellow and the acute stroke nurses are pre-notified that the patient with a stroke will be coming to Canberra Hospital or Kalbarri Hospital. In Kalbarri Hospital, we are doing lysis, but in Kalbarri Hospital, but at Canberra Hospital, we are doing both CPA and ECRs. And as a community health pathways, as GPs, you should do several things for previously TIA and the stroke patients. They are assessment and management. About assessment, if queries patients come that is not 100%, you are not 100% sure that this is TIA or other differential diagnoses, there are some clinical hints for you. TIA and stroke is rapid onset, but other differential diagnosis is mostly subacute onset and on and off manifestations and undulating manifestations. Also, for stroke and TIA, the maximal neurologic deficits is reached at seconds, and stroke presented with focal symptoms. Stroke mimics are confusional states. For confusional states, excluding dysphagia, actually TIA can be ruled out if the patient is bewildered, confused, drowsy, without focal neurologic deficits. Other differential diagnosis should be ruled out first. Another differential diagnosis is syncope with passing out and blacking out. Dizzinesses are differential diagnosis of stroke, but true vertigo is most probable with a stroke. Generalized weakness is not a manifestation of a stroke. Bilateral blurred vision is most probably is not a manifestation of a stroke, and particularly scintillating scotomas and flashing lights that we usually see in migraine patients are not seen with stroke patients. Also, incontinence, bladder and bowel incontinence is not a usual and routine manifestation of a stroke. Okay, about management, we have antiplatelets, we have anticoagulants, BP management, statins, and particularly I ask from respected GP for long-term management of stroke patients in terms of risk factor management, optimizing comorbidities, and particularly about driving. Driving is a very important issue. Driving should be safe for both patient and other drivers. According to rules and regulations of many states of Australia, all states of Australia, actually after TIA, patient cannot drive for 2 weeks, after a stroke for 4 weeks, and for his stroke manifesting with visual field defects or diplopia, the patient should not drive unless optometrist clear them. It's very important. For motor and sensory strokes, 4 weeks. But if the patient has any visual or ophthalmoplegic manifestations, the patient needs optometrist clearance for clearance of driving. Okay, and other things, our referral, if a patient with TIA was seen in your local hospitals and then come back, if the TIA finished, there's no need to another referral, and you can manage TIA stroke patient by yourself. Just in 2 conditions, refer TIA clinics again to your local hospitals. If the patient has ongoing symptoms and if the patient has crescendo TIA. Crescendo TIA is defined as more than 2 TIA per week. If your patient has already done all management of stroke and TIA, and again has more than 2 TIA per week, please refer the patient to local hospitals. And make sure you and your patient understand how to access services available in your area. Coming back to David, David was transferred to a stroke unit to the nearest hospital for assessment and management, arriving within 2 hours on symptom onset. So in the window, David was on dabigatran, and unfortunately we have a dabigatran reversal agent called idarucizumab. Idarucizumab actually infused to David, and then David can receive thrombolysis. David actually received thrombolysis, and just like Lillian, actually Lillian's story was so impressive for me. Stroke neurology is a very stressful specialty, but the time that I noticed that there is a stroke victims that is independent, can talk to you, it's a very good incentive for me. Okay, so secondary prevention and should be considered for all the stroke victims. I want to express my sincere sense of gratitude and to you for being in this stroke teaching module. Thank you everyone.
So much, Ashton. It's such an important presentation and it was so informative. So thank you. Now, everyone, a friendly reminder, I can see some questions coming through in the Q&A. So thank you. If you have any other questions, please pop them in the Q&A and we will go through those during this time. If you see a question that you think is really important and you would like answered, please give it a thumbs up to upvote it to make sure that we get to your question before the end of the webinar. Now, before we start, I would like to first direct the first question to Lillian. Now, Lillian, I would like to ask you, what was the most heartbreaking observation of stroke that you have? And that could be, from a personal perspective or from a wider community perspective.
Okay, so that's actually a hard question because I find I've met a lot of stroke survivors, either through the Stroke Safe Speaker scheme and through my own talks, and every story is actually heartbreaking. The ones that really make me quite sad would be the ones that happened to younger people. And the one, and there's quite a few people who've spoken about, family members who are passed. So they're all heartbreaking. But I'm thinking I'll share something, and it's sort of a bit, it's Dr. Afshin sort of touched on this as well, about the hidden impacts and how people can come out, you can have a stroke and you can feel quite depressed about it afterwards. Well, good, and it's heartbreaking to me even as I speak about it, but when you have these days, technology is great. So you get the thrombolysis, you get thrombolytic, that's great, you get the clot retrieval, but the clot retrieval is done so well, you don't come out with a bandage on your head. Okay, so people look at you afterwards and they think, oh, they're fine. There's nothing wrong with them. Did they did they even have a stroke? So I think that was what hurt me a lot, that people didn't really want to know about how I really was. And I'm not sure what we can do about that. But I think it would be great, obviously, that when you are referred, or when you go back to see your GP, that you actually get the empathy there. I think that would be lovely.
Thanks, Lillian. That's a really, really important perspective to share. It is so hard, and there are so many impacts of stroke that we just can't see. So it is really important to ask. Thank you. I'll go to the next question. We do have a few questions in the Q&A coming through about TIAs. So I will start with the first one and we'll make our way down. So I might direct this to Sharla and Dr. Afshin. So there is a question in the chat that if TIA occurred greater than 7 days ago, what's the difference between the care that the TIA clinic will provide and the care that GPs can provide?
Sharla.
Hello there. What we've asked for is just due to the volume of patients who present to the hospital after 1 week, that the GPs would request the initial imaging. So we're asking that GPs request a non-con scan and then a scan with angiogram, or if the patient's got any contrast allergies, we ask if they can do carotid Dopplers. Once those scans have been done, we also ask a fasting pathology slip to be sent, and then you to refer at the same time to the TIA clinic. Once it's over the 7 days, the categorizing of them is a little bit slower, just because in that hyperacute window, the risk of a further event is slightly higher, and we've already went past 7 days. But we still recommend quite strongly that patients are referred to the TIA clinic so we can assist with ongoing management and interpretation of the CT results and work up a plan for antiplatelets or appropriate risk factor reduction.
Thank you so much, Sharla. We have one more question on TIAs as well. So thank you, Tracy, for your question. So it's about people who have TIA who go to the Canberra hospital getting aspirin and clopidogrel and then for 3 weeks and then going home. So just asking for a comment if this is a local practice that's happening in Canberra.
Please comment on PFO as a risk factor. Tracy, actually, I have about 20 years of experience with the stroke and neurology, and the PFO is the subject that changes every 4 or 5 years. It's changed a lot and a lot. But the most recent guideline is if you confirm that PFO is the cause of stroke and the patient is young, about less than 60, you can proceed to PFO closure. But you should show that the PFO is the cause of stroke and other causes such as antiphospholipid antibody syndrome, thrombophilic state, and most importantly, thrombosis in venous system, not only in the lower extremities, but also in the abdominal and pelvis should be ruled out. Nowadays, if you show that PFO is the cause of stroke and there is a significant significant right to left shift, yeah, PFO could be closed, and I think that we have knowledgeable and skillful cardiologists who do PFO closure very efficiently. Kyla? Kyla?
Yeah.
I'd like to answer Dr. Peter Cole's question. It's very important. And after that, Charlotte can have a comment about dual antiplatelets and the duration of dual antiplatelets. Guys, actually, Chance's study and Pointer's study showed that for small strokes, small in terms of NHSS and in terms of actually radiologically small strokes, we proceed to dual antiplatelets, both aspirin and clopidogrel, but just for 3 weeks. Just for 3 weeks, we prescribe aspirin and clopidogrel, because the risk of recurrence of ischemic stroke for small strokes and TIS for 3 weeks is high. And after 3 weeks, we exclude one of the antiplatelets. Most of the time, actually, we proceed to just aspirin. So for small strokes, low NHSS, and small ischemic strokes in terms of CT and MRI, and also for TIS, you can proceed to dual antiplatelets, aspirin and clopidogrel for 3 weeks, and then after 3 weeks, just aspirin. About anticoagulation, actually, only strokes that AF was found, atrial fibrillation or atrial flutter was found, you can proceed to anticoagulation. Actually, there was some trials for ESUS, I mean embolic stroke with undetermined causes, but unfortunately ESUS trials failed, and again we cannot proceed to anticoagulants for strokes that we presume they are embolic, but AF was not found. I think that I would like that Charlotte a little bit explain about our heart bag and the technology of heart bag that we have in ACT and we have in all the states of and territories of Australia.
So the goal, especially when we have imaging that is suspected of a cardioembolic nature, when a patient's admitted through the hospital or even if they come through the ED department, they only have a short snapshot, a maximum of 48 hours of telemetry, which just isn't a long enough period to detect atrial fibrillation or any underlying arrhythmias. So as part of the process of being referred into our TIA clinics, we now have portable Bluetooth-led monitors, which are called heart bugs, that we can give the patients that can allow them to have 30 days, which is Medicare bulk billed, of cardiac telemetry. The benefit of these devices are that the Bluetooth-led, so we get real-time data fed back through the patient's telephone, which leads to real-time alerts. So it means that your patient isn't wearing a device for 30 days, then someone reports it and the report lands on your desk 2 months later, and then on day 3 they had atrial fibrillation. This is the Bluetooth data is uploaded to the device, it's sent through to the company look at it within 24 hours, we get an alert, and within the next day we're contacting the patient and yourselves to say, we found an arrhythmia, we are recommending the commencement of this medication, can you please facilitate that?
That's brilliant. What incredible technology that's happening all around Australia. Thank you, Shala and Afshan. We have another question that is along the lines of medication and the case study that Afshan presented today. Someone has asked that if David in the case study had been on Axiban or Referral, apologies for my pronunciation here, and had taken it 2 hours ago, would you still use a thrombolytic?
Very clever question. Very nice question. You know, for rivaroxaban, we have idaruximab, but unfortunately, for apixaban and rivaroxaban, we don't have, chelating agent. Actually, for apixaban and rivaroxaban at ACT, we check activated factor 10. And if activated factor 10 is less than, in limit, I think less than 10, we can proceed to thrombolysis. But most of the time, if the patient is in, it's two conditions. If the patient has large vessel occlusion, most of the time we proceed to endovascular clot retrieval. But if the patient has no large vessel occlusion and still in the window, we check factor 10, active factor 10. If active factor 10 is less than 10, we can proceed to lysis. So it's not impossible to proceed to thrombolysis for patients on apixaban and rivaroxaban, but it has its own limitations.
I'd just like to add as well that those drugs, when given within 24 hours, are a contraindication. It's after the 24 hours that we can consider it with the anti-factor XEA blood interpretation results. So unfortunately, as the question's being posed, if a patient disclosed that they'd only taken the medication 2 hours prior to presentation, they would automatically be excluded from thrombolysis. But as Ashvin has said, we could still consider them for endovascular clot retrieval.
And thank you so much. The next question we have is, so do you advise that anyone with a TIA or stroke and in sinus rhythm needs a cardio echo?
Charlotte?
I'm sure everyone's familiar working in the SAT that access to echoes is quite a difficult process. We tend to look at imaging and try and work out more if we think it's a cardioembolic focus, and that dictates our guidance towards requesting an echo. We don't request them as standard because we understand the wait list is high and the likelihood of them getting it within a sensible time frame is a little bit lower. So we normally focus more on the heart monitoring to look for any underlying arrhythmias, but we would certainly recommend a referral for echo, especially if they've got a private cardiologist that are already under, to assess for any underlying structural abnormalities if you're suspecting that it's a cardioembolic in nature or if the patient has increased risk factors.
Totally agree. Totally agree with Charlotte.
We have some questions on prevention as well. So there was another question, is there an age limit where you consider the risk of starting anticoagulants outweighs the benefit? So for example, over 90 years, or if there are additional social factors involved, like they live alone and maybe at risk of falls.
Again, very clever and nice question, I think. We have guidelines. Guidelines do not consider any risk, actually limitation of age. For apixaban, we have some limitation. If the patient is more than 80 and creatinine is more than 1.6 and also another risk factors, then the dose will be 2.5. More than 80 creatinine is more than 1.6, and another thing I forgot. But actually, there is no limit for age. But guidelines, I always think to individualized medicine. Yeah, if a patient lives alone and had history of recurrent falls and also history of, for example, subdural hematoma, epidural hematoma, we should negotiate with the patients. We should know that if the patient has AF and developed a stroke, antiplatelets are not strong enough to prevent another stroke or TIA. But the risk and benefits of anticoagulation should be negotiated with the patients and family members. The thing that I can say that, because I'm from the generations that both experience warfarin and drugs, the bleeding risk with drugs is much significantly lower than warfarin. But I do agree with my GP colleague that other factors, such as particularly recurrent falls, should be considered. At the moment, there is no age limit. We can change the dosage, but there is no age limit. But social and personal factors should be considered as an individualized medicine.
Did you want to look at anything to that question? No? Okay, perfect. We'll go on to the next question. So one question here is how the primary and secondary stroke management differs. So what do you do different for primary and secondary stroke prevention?
Shala?
So with your primary prevention, it's more about doing the initial workup to try and understand what those risk factors are. So we're doing the imaging to see if it looks like it's cardioembolic, to see what the underlying vessels look like. Is there a high level of vessel disease? Is there atherosclerosis? And then referring to the clinic where we would look at the images and try and work out what category or what underlying etiology there is for the patient. That would be the primary survey where we're trying to see if we can work out what we can do to immediately change the risk. With regards to secondary prevention, we're talking about risk modification for lifelong changes. So 80% of those strokes are preventable if we have early discussions with regards to management of hypertension, dietary changes, understanding any underlying diseases and optimizing chronic disease management. So having a good understanding of your patient, and as Afshan said, just constantly encouraging them to come back every 6 months or so to repeat the cholesterol, to see how the blood pressure's going, because those single agents are not necessarily working for those patients, or they might just write off that I had another funny turn and not have actually presented anywhere. So then they need reassessing to see if they have ongoing risks that they've unintentionally wrote off because they thought it was nothing.
Kyla, as an addendum to previous question, we have CHATS-VASc and we have Hasbled. Actually, a Hasbled score can predict the risk of bleeding for both warfarin or drugs. Hasbled, H is hypertension, A is abnormal renal function or liver function, S is stroke, B is history of bleeding, L is labile INR, E is elderly, age more than 65, and D is drugs. I mean that NSAIDs, other drugs, and also alcohol consumption. So our respected GP colleagues can consider, can calculate Hasbled and also consider personal and social factors like recurrent falls, living alone, and then negotiate with the patients. As higher CHATS-VASc and lower Hasbled should persistently go to anticoagulations, but for higher Hasbled, some negotiations with the family is necessary.
Brilliant, thank you. There's another question as well on hypertension. So Peter has asked, is systolic hypertension more important than diastolic or vice versa, or is there no difference?
I start the answering and Shala can comment on this. No, both of them are important. In previous literature, just diastolic considered, but recently both systolic and hypodiastolic are important, and they should be managed and they should be monitored. Shala?
Yep, completely agreeable. And just remembering that just prescribing the tablet isn't the answer, especially if they're able-bodied or have a good quality of life that allows them ability to talk about increasing cardiovascular resistance. So the importance of exercise and staying mobile to help reduce that blood pressure alongside the dietary changes.
Thank you. It sort of brings me on to the next question. So someone has also asked about other medication recommendations for primary stroke prevention. Dr. Afshan or Shala, would you like to answer this question?
Actually, the Stroke Foundation slide set was totally and thoroughly accurate. And we have some, unevidenced things, for example, vitamins or other things. But the things that I said, risk factor management, management of hypertension, bad cholesterol, diabetes mellitus are the most important. Other things are mostly unevidenced. Shala?
Yep, I agree. So we're asking for referral into the clinic so we can offer that initial support. But as far as we are aware and what the evidence has shown is that we normally go along the lines of dual antiplatelet, depending on if they're moderate or minor, single if they're a high risk, and then of course anticoagulants further down the line if they're found to have arrhythmias alongside the preventative risk factor reduction methods.
Brilliant. Thank you both. Now we have a few questions also on thrombolysis. So one question was, is thrombolysis indicated regardless of the type of stroke? Can we diagnose a stroke as well on history and physical signs alone?
There are some hints that, for example, embolic strokes reach the maximal intensity very soon. And embolic strokes, we have embolic strokes and hemodynamic strokes. Hemodynamic strokes are dependent to the position of the patient. For example, if the patient has carotid stenosis more than 99%, this patient can develop some TIA-like manifestation in orthostatic changes. But, it's not 100%. But indications and contraindications of TPI thrombolysis is regardless of the cause. Even for dissection or fibromuscular dysplasia, if it's within the window, you can proceed to thrombolysis. So to my best understanding, it's regardless of the cause. The indications and contraindications are mostly time dependent, and contraindications like recent surgery, recent GI bleeding, platelet less than 100,000, INR more than 1.7, blah blah blah. But it's regardless of the cause, to my best understanding.
Fantastic, thank you. Charlotte, did you want a question?
I think there's not much more to add apart from you can have some handy hints and tips for history, but without the magic scanner, without them going through a CT, we just really don't have the answer.
Yeah.
We have one more question on thrombolysis. So someone has asked that the Canberra Hospital thrombolysis and clot extraction unit was Monday to Friday and operating during working hours. They want to know, is that now 24 hours a day, every day of the week?
Yep.
Brilliant.
This is correct. So no matter what time of day when you present at Canberra Hospital, we can offer thrombolysis and clot retrieval. It's 24/7, and we also support 6 sites across rural New South Wales. So we're always on, always ready to activate the angio suite as we need. With regards to Calvary, of course, they don't do clot retrieval, but again, their thrombolysis is 24/7.
That's brilliant to know. We also have another question, which is if a patient's back on TIAs again, but if a patient presents after 48 hours and within 7 days, do we need to send them to the ED via an ambulance?
Sean?
I think when we've touched briefly on the pathways, and I believe there's logins that you can access, and we've now updated what our preferred stream is for the ACT, we're recommending that unless they present to use within, whilst the symptoms are ongoing or the crescendos are high risks, that you request the initial scan, so the CT, plain brain, and the angio, and the fasting bloods, and refer them to the clinic. The only reason we'd be asking you to refer them immediately to us is if you were very concerned because they were high risk, or if they're presenting to your door with ongoing symptoms, or you do not feel comfortable at all managing them and you need that extra support.
Brilliant, thank you, Charlotte. I think it's really important to mention those pathways again. So they are a really great resource for GPs in the ACT. So it's got all the guidelines in there and also all of the ACT local practice as well. Now, I have a question for Lillian, which I think will be a fantastic one to wrap up the session if we don't get any other Q&As questions tonight. So, Lillian, I'd love to hear from your experience. What is your advice for GPs in terms of educating their patients on the fast signs of stroke, but also on prevention?
Okay, well, I'm going to draw on my experience as a stroke safe speaker. So it's, you know, the responses that I've received when I've asked questions to the audience. So one of the questions that I do ask is, you know, because I say it's important to have regular health checks, particularly if you're over 45. And I ask, okay, so who in the audience has regular health checks? And I'm actually always surprised that how little people put their hand up for that. So I was trying to work out how that number could be improved. Now, whether they see GPs occasionally or not, you know, I think it's about, you know, it's about making that connection and to remind people that that's what they should do, you know, and then so having the health checks and then having all the wonderful handouts that are available through the Stroke Foundation available at the practices, and then obviously having everyone trained in the practices to be able to recognise the signs. Yeah.
Thank you, Lillian. It is so important that everyone can recognise the signs. I can't echo that enough. It's really important, obviously, that health professionals do, but also the community, practice staff, receptionists, everyone can recognise those signs, because, you know, we need other people to be able to recognise them. So the person, doesn't matter if the person themselves knows them, we need other people around them to recognise them and call 000 to get to them in an ambulance and off to the hospital for quick treatment, because every second counts with stroke, so time is brain. Thank you so much to all of our panelists today. I'm going to end the conversation there, but I really want to give a big, sincere thank you to you all for your invaluable insights and knowledge into stroke management in general practice, specifically within the ACT tonight. I really hope this webinar has installed confidence in everyone who is listening to go out and use what you've learned tonight to make practice change in your clinics and teach all of your practice staff as well about the fast signs to optimise stroke patient outcomes. Now, at the very end tonight, before we end, I would love for everyone to complete this short poll as a post-webinar poll, so we can see the differences in your answers.
Kel, I think pretty much around 90% has completed the survey, the poll, sorry.
Thank you so much. Well, thank you, everyone. I hope you have a fantastic night. Thank you for joining us. We really hope you learned something tonight. Thank you, everyone.
Thank you.
Thank you.
Thank you.